TIAs and stroke, an overview. There are two major causes, actually. There are three major causes. You either bleed into your brain, you've sent an embolus to your brain, or your brain's decided to go like that. It's squeezed down. So it's thrombotic, it's embolic, or it's hemorrhagic. Those are the three. By the way, it's about 15 to 18% are hemorrhagic. Then the embolic is relatively rare except in certain groups. We'll talk about those. Most everybody else is thrombotic. Ischemic events usually present with a constellation of symptoms which tells us where the lesion is. Now, you know that of the 10 studies of TPA, non-TPA treatment, 2 of the 10 are positive. 8 of the 10 are negative. And those 2 which are positive deal with anterior circulation TIAs and strokes. Anterior circulation. This is important. Remember, I said there's things you need to know, you don't need to know. The 2 medical disciplines are cardiology and neurology. This stuff is real. Here's some brain vascular anatomy, and what you will notice, this is looking at the underside of your brain, obviously, and you're looking at the circle of Willis and the pituitary gland. You will notice that they point there to the anterior cerebral artery. Then there's also a point to the basilar artery system, the middle cerebral artery. Most of us are used to, on a statistical basis, if you are going to stroke, on a statistical basis, about 80% of them are anterior, about 20% are posterior circulation. But they have different signs and symptoms. You know, the brain is hugely interesting, because if you look at it, it all looks the same. Remember, if you take liver, liver is liver is liver. It all does the same stuff. The brain doesn't. The brain is so somatotopically arranged. Little areas in various places do quite different things. So you may have somebody with a stroke, they have not very many symptoms at all. Some people with a very tiny one will have huge symptomatology. Individual pieces, the brain may look the same, but it does a lot of different work. The other thing is we have dominance, all right? We have a side of the brain which is kind of in control. That varies. Most people who are right-handed, well, all people who are right-handed are left brain dominant. And about half those who are left-handed are also left brain dominant. So there's about 4 or 5% of people who have a difference in their dominance, and that actually does make some difference occasionally. I'm not going to go through every localization technique because this you need to study. This material in this part of the book is you commit to memory. And then I'd keep the book around the department so you can check. But understand symptoms are occurred based on the vascular anatomy, and each one of us has our own vascular anatomy. Those are the arteries that you need to know and what they supply. 1, 2, 3, 4, 5. Don't know those, you don't know nothing, so to speak. Middle cerebral artery, TIAs, are the big ones. Middle cerebral artery that affects your dominant side is the one that makes you go, yeah, 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 yeah. It makes you not move your right arm or your right leg. Usually arm is more affected than leg. It can make it so you cannot interpret words and phrases. It does all kinds of things. In big strokes, you may, by the way, to become unconscious, we don't have a talk in this course on stupor and coma. We should, really. Because stupor and coma require that you've affected not just one hemisphere, but something posterior. Most people who are in coma have involved both halves of the brain in one way or another. Coma is a bad finding. Coma itself, when they come in coma and somebody says, well, I think he's had a stroke, Don't be reaching for the TPA, because if you score that patient, they don't score well on the NIH stroke scale. They're not going to get it. They do not have that kind of lesion. Contralateral if the left side is involved, the right side of the body. Now, I'm going to give you a clue which will be good till the organism mutates. Think about this. Until we change our anatomy, if you have face on one side, body on the other, right side or left side of the face, right side of the body, that lesion must be in the brain stem. You can't put that anatomic lesion anyplace else. That's a brain stem lesion. Most brain stem lesions are not eligible for TPA. Aphasia, almost always involving the dominant hemisphere. And when you're unaware of symptoms, I don't know whether you've ever seen this or not, but you have people who the non-dominant hemisphere is affected, and the brain refuses to recognize that side of the body. I've had them to the point where I could show them the hand on the left side. They didn't know whose hand it was. So they have an extinction phenomena, very strange. The middle cerebral stroke, again, you can see the areas that it involves, but if you look at the motor output and the sensory input, they have the homunculus drawn there. These tend to be sided lesions. Whenever you have sided lesions, you're almost always dealing with the cortex of the brain. Non-sided stuff, both-sided stuff, and cerebellar stuff is the posterior fossa. That's kind of the way they are. We're going to move on here for a second quickly. Notice, here's the CT of a large area of infarction. You see all that area over there. That's huge. Now, it's probably unlikely that that's just one vessel. You may have two vessels involved in that case. We're going to move on just a little more quickly here so we can make sure we get to everything. Here's the posterior cerebral artery. It goes to the back. Now, understand the posterior fossa has about 15% of the volume of the brain, but it has all the important stuff. This is what keeps you alive. This is where you breathe. This is where you move. This controls coordination. So whenever you see somebody come in and they can move the arm, but you've got this, or they walk, they cannot balance themselves, this is almost always in the posterior fossa. That will influence your decisions on whether somebody gets any medication at all. The vertebrobasilar system, as we talk about, going right down the center of the basilar artery, it glues to the back of the brain stem. It's glued there. So you frequently get both sides affected, not one side. Often you get symptoms such as ataxia, headache, nystagmus, cranial nerve findings. Whenever you have two-sided cranial nerve findings, it's in the posterior fossa. Just like I said, whenever it's face on one side, body on the other, it's in the brain stem, almost always vertebral basilar system. All right, what are lacunes? This is a C. Miller-Fisher finding. Miller was probably one of our most famous neurologists in the United States. Very interesting guy. C. Miller-Fisher found out that there'd be little tiny penetrating arteries in the brainstem which cause problems. These are small diameter arteries that arise mostly from the middle cerebral artery, but they can give you pure motor hemiparesis. That is, if the only finding are the arm and the leg, no sensory stuff, no anything else, that's almost always a motor lacune. That's a little tiny artery. There is no data to suggest that this is influenced by TPA. Not one bit. not a whit. What about, let's talk for a minute about transient ischemic attacks. These are abrupt onset of neurologic symptoms in a vascular distribution. We have to understand it as being able to find avascular distribution. Usually lasts no more than 30 minutes, but can last up to 3 hours. Majority last even less than 10 minutes. Consideration of TIA will often be based on history, patient, family, other attacks they may have had. Now, there are findings which are not suggestive of a TIA. What are those? If you ever lose consciousness, that means both sides of the brain were involved. It's unlikely that was a TIA. That was more likely your ventricular fibrillation that cleared itself. You've got a loss of blood supply to both sides of the brain. Certain kinds of vertigo, or certain kinds of dizziness, not vertigo, but drop attacks. Some people call dizziness drop attacks. Generalized weakness, all areas of the body are almost never a TIA. How would you get that? Where would you put the anatomic lesion which would cause weakness on both sides of the body? I have no idea. And I used to teach neuroanatomy, and I promise you I can't find that spot. Loss of vision completely always means both sides of the cortex and the occipital lobes were involved. And incontinence, as the only finding, is unlikely to be a TIA. Again, if you've got somebody who has diplopia, it's unlikely that that's a TIA involving the major arteries of the cortex. Diplopia almost always takes place at the brain stem level. Loss of balance, tinnitus, the ringing in the ear, is almost always a localized phenomenon, not the major arteries. Scintillating scotomata, funny lights in a distribution, may be seen, of course, with migraines, rarely seen with TIAs. Drop attacks we've talked about, and isolated dysarthria is almost never a TIA. What's the TIA differential diagnosis? When you think of somebody, say, what's the matter with Grandpa? I don't know, his hand kind of went funky, and this side of the body didn't move well, and he kind of went like this, and his face drooped. Okay, how's he doing now? He's getting a little better. Make sure you check the med list. Hypoglycemia should be generalized. In 50% of cases, it's not. Hypoglycemia can present as a focal neurodeficit. Don't ever give anybody TPA where you haven't checked the blood sugar. That would be verboten. That would not be good. What about structural brain infection? Almost always both sides involved, but can look like a TIA. Seizures, post-seizure. A certain percentage of people, that's why you always get the best history you can. What were they doing? Well, they kind of went down. Ask them. Were they jerking their body? Were they moving? Because you can have a Todd's paralysis for up to an hour after the seizure, and it slowly gets better. The last thing a seizing patient needs is TPA. Complicated migraine, a multiple sclerosis flare. They put this on the slide set. I've never seen this confused with a TIA. Multiple sclerosis, if we know they've got multiple sclerosis, it's patchy. It has nothing that looks like it's one distribution. That's not multiple sclerosis. And obviously, hyperventilation syndrome, are there still people who come in and want to be sick or think they're sick? Those are the tough diagnoses to make because they may have read too much. They may have studied this up. Now they're projecting it onto themselves. I've had several of those people who came as close as you'd ever want to getting a medicine that can kill you. Always think about that. All right, what's the TIA evaluation? Thorough history, physical, document the vital signs, whether the heart is regular or irregular. Stop. If you've got a patient in atrial fib not being treated, what are the chances they're throwing emboli from that heart? They're reasonably good. There's a reason we put you on Coumadin if we can't straighten out the rhythm, and that's to stop you from throwing emboli to your brain. People who have atrial fibrillation can have serious problems. You want your good neurologic exam there, and all of you should pull out the NIH stroke scale. This isn't a memory game. You just score it like you see it, because you're going to have to make a decision, and you may have to defend that decision in court, I promise you. Check the neck for bruits, because the two places emboli come from are your neck and your heart. So you're looking to see normal sinus rhythm or something like that, yes or no. Any possibility it's coming from the neck, yes or no. Those are going to help you make some decisions here. Obviously glucose, obviously EKG. Now, what's the value of the CT in looking at people to decide if they've had a stroke? There's only one value right now if you follow the NIH literature. You realize this data is 20 years old. This paper in the New England Journal was published in 1995, which means some of the literature goes back 5 years from there. The function of the CT is to determine one thing. Are they bleeding, yes or no? And if you feel comfortable looking at that film and making that decision, good for you, because I don't. I want somebody who's a neuroradiologist to look at that film and say yes or no, because the consequences are big. Consequences big. I would point out to you that TPA is the only medicine we've ever had in the emergency department where, in the best of hands with the best of experts, 1 in 19 people, 6%, bled into their brains. The lucky ones died. The worst were crippled forever. 1 in every 19. That's the number out of the NINS trial. 6% got worse, 12% got better, and 80%, it did nothing at all. What about the MRI? Well, it's very interesting. There is no literature using the MRI as the control to decide whether we're going to give things. The one thing the CT scan can tell you besides bleeding is if you actually see the infarct on the CT, what you know is it was a long time, it was 12 hours ago or more. Some people say it doesn't become really positive for 24 hours. But if you do this and you look at the area involved and you say, well, that's an infarct, they're not eligible for TPA. It didn't happen during that time frame. What about MRI? The problem with an MRI, and though it's now being used for stroke, is we don't have validation of what it means. It's not part of the decision to give TPA at this moment in time. Will it be? No question. It's just not there yet. So how do you treat TIA? If they're starting to get better, do nothing. The hardest thing for medical people to do is put their hands in their pockets and do nothing. Because you think, hey, they came in here, they're paying a lot of money, I ought to do something. No, sometimes doing nothing is good. Do not drop their blood pressure, except in unbelievably acute cases. So they got an elevated blood pressure. The brain is sending a message. I need the blood flow. Do not drop their blood pressure. Keep them normally hydrated. Give them an aspirin. And any TIA patient I see, I give them an aspirin if they're not on something, if they're not on Coumadin, something like that. Why? Why not? You know, you can buy like a jug this big of aspirin, at CVS for about $2, okay? Open their mouth, throw it in. I've never seen that hurt anybody. Clopidogrel is not in that class. It adds very little. It's got complications. So if they're already on aspirin, don't give it to them. Probably not good. What about the TIA disposition? What are you going to do? Here's what we do at this moment in time and what's happening in a lot of hospitals. Patient comes in. They're feeling a little better. They go to the observation unit. They get they've had their EKG. They are going to, in the next 6 hours, have a study of their carotid arteries. Blood pressure will be normalized. All the usual things will be looked at. They are then seen by the neurologist before they leave. And within 12 hours, most of them are gone. They don't have to be admitted to a floor someplace. What you have to have is this. Is there anything that we found which is surgically correctable or mechanically correctable, such as a fibrillation or something like that, that we can do something about? Other than that, they can go home. Let's say a patient comes in with a TIA, and 6 months ago, you know, you've checked the strip, normal sinus rhythm. 6 months ago, they had studies of their carotids. Do they need to have them done again? No, they don't. You're not going to build up plaque and that sort of thing in the past 6 months in those arteries. Make sure they're on their TPA. I know, but nobody likes this. You talk to the families. They say, could they stroke? The answer is, yes, they could. Can I do something by putting them in the hospital? Yes, increase the risk of getting a pulmonary embolus and catching a terrible disease, which we've got running around this hospital. People always forget the most dangerous square footage in the community is the hospital. All kinds of people die there, right? Well, almost nobody dies at Kmart. So why don't you send them to Kmart, okay? We went through the ABCD D-squared scoring system to risk stratify. The only problem is it was very good as we thought about it, and then when it was applied to the public, it didn't work. Here's the scoring system. Are you above age 60? God, I hate this score already. Yes, I am, you jerk face, okay? We talk about the blood pressure a little bit. Clinical features, unilateral weakness, speech impairment, duration, all these sorts of things. The problem is it was a very poor predictor of who was going to go down at any one moment in time. Now, let's get into some real numbers. There's the standard workup in the hospital. Echocardiogram, carotid studies, some places will do an MRI, some will not. So now we've got patients who do not resolve their neurologic findings. Here is the #1 question you have to ask. If this is not on your chart's a failure. Who was the last person to see this patient normal and when? If grandpa went to bed last night, I hate that because I'm somebody's grandpa, okay? But you go to bed at 8 o'clock, at 8 o'clock in the morning, you're sort of curled up in bed. Are you eligible for TPA, yes or no? No. And everybody's heard the crap on TV. We want the magic clot buster medicine. You've got a big job here, ladies and gentlemen, to tell them, no, that doesn't work in certain cases. May present subtly, but you want to know when you honestly think this took place. In ischemic stroke, time is of the essence if you believe that TPA works. But even the masters of TPA know that there are time limits here. By the way, you've all heard about, how many people have heard about the extraction of the clot from the brain? Radiologists putting the tube up and extracting. You realize there were 2 papers published in the last couple of weeks which say that's horseshit. They cannot prove it. Are there some people who get better? Yes, but there's some people who get better if you do nothing. There is no good evidence to suggest that sucking out the clot actually works. So just kind of keep that in mind. And people say, well, can't you go in and get it? Because there's some people who've read about this. They've gone online. Oh, God protect me from the person who's online and comes in, well, we've printed this off. Great. Do you think there could be any lies on the internet? Yeah, sure. Okay. So think about all of these things. Initial stroke treatment, if comatose or altered, maintain airway. But patients who are in coma are not going to be getting TPA. Monitor blood pressure. Notice I didn't say treat the blood pressure. Cardiac monitoring, that sort of thing. Once signs and symptoms of a possible stroke are identified, this is the usual number of things that we get. Now, you've got to review that patient history with the family and be sure. Do the NIH stroke scale or the Canadian scale, whichever one you want, but use one. Controlling the blood pressure, I said, is controversial. Only in extremely high blood pressures do we bring it down. Now, here is something that no one has the answer to. This was in the first iteration of TPA. They said, well, if their blood pressure is elevated, drop it to under a systolic of 185 and then give the drug. Does anybody know the study where that came from? There is no study. They said, that seems like a good idea. I actually was on the stroke intervention group at the NIH at that time and said to Walker, who was the neurosurgeon running the thing, I said, can I have the site on that? He said, well, there's no site, but we thought it was a good idea. That's their view of science. I mean, it was embarrassing. It was absolutely embarrassing. So you can consider doing some of these things, but be careful. Do not intervene unless blood pressure persists over 220 over 120, and then minimally at best. Hemorrhagic stroke, if it's a hemorrhagic stroke, you do the CT scan and there's blood. Now, there's some data to suggest that we probably ought to at least back them off a little bit. We take them from their 220, 240 numbers back down to 185. That's probably not a bad thing to do. No one has good data on this yet. It's just what's sort of being done in the community. Let's move on for a second. Here are the treatment guidelines, the American Hospital Association TPA treatment guidelines. These are the things that if you look at these things, there's neurologic signs and symptoms. They score a certain level on the NIH scale. You know when it started. And I want to make sure we get to this so it's clear. The 3-hour, the initial study, NINS, was up to 3 hours. If we take ECAS 3, by the way, if it's an ECAS 3, doesn't that presume there was an ECAS 1 and 2? Yeah, they were failures. They didn't go well for the drug. But now they've extended it to 4.5 hours, or see, some people have. How many of your places have extended it to 4.5? Understand that this is, again, controversial. There are some additional exclusion criteria. You ought to go through that and make sure of what you've got. Now, here is the most important thing I can tell you. And I'm telling you this as our time is running out. Number one, if your center believes in this, and you've got a neurologist and a stroke team and all this other crap, then you sit and talk to the patients, but what you have to tell them is the truth, i.e., about 6% of people did worse, 12% of people did a little better, and 80% of people, it didn't make any change at all. Those are real numbers. Those are something you can relate to. Don't oversell this because it's not good. Mistake number two that I've seen most of the suits on. You're at a small hospital someplace. You say, well, we send them to a stroke center. If you're going to be part of a TPA network, The sending them to the stroke center may put them outside the window, right? So if you're going to do it, do it. But don't be sitting around there waiting to answer questions in court about if you knew they were going to give it, why didn't you give it within the time window? That is the most common lawsuit I see is delay, delay, delay. Time is brain. That's the mantra they use. When would you like it done, doctor? That sort of thing. So keep that in mind. If you're going to do it, do it. Don't be cramping around. I'm not going to get into dosing because that's really something else. But when I want to make this point, if you believe we know what we're doing yet in stroke, you're smoking dope, okay? You are. There are zealots on both sides of this issue. Your job is to give patients and their families some honest ideas. This is what we might do. No guarantees here. And that's where we are today in stroke and TPA. Ladies and gentlemen, thank you very much.